So visiting the doctor, taking care of your health, doing the right thing is okay. So let me start by doing a case presentation. And a case presentation is a short summary about a patient. So our patient, this is the pictures, and the name, of course, are fictitious. But we're going to call our patient today Jojo, okay? So Jojo is a 46-year-old Asian male who was referred to our clinic, the gastroenterology clinic, for evaluation of hematochezia. Hematochezia is a term used when people pass blood in the stool. So he's a very pleasant person, very kind, full of energy, full of zest, and he questioned himself, I don't know what I'm doing here, doctor. I think most likely, when I pass blood, most likely it's hemorrhoids. So anyway, she said, I just have this intermittently, once in a while, I have a little bit of blood when I push too hard, and again, I think this hemorrhoids. He has, when we look at his past medical history, meaning what medical problems he has a body mass index of 35. What is body mass index? Body mass index is a multiplication or a calculation of the height of the person and the weight. And basing this calculation, they give us an average to decide if the person has a normal weight or not. So ideally, I want to remember this number. The ideal BMI or body mass index is 25. So when you go from 25 to 30, you are overweight. When you pass 30, you are obese type 1. When you pass 35, you are obese type 2. When you pass 40, you are obese type 3. In fact, I was thinking about having our BMI measured today, but I think probably some people may get offended, so I stop it right there. But anyway, this person have a BMI of 35, which means was obese type 2. He also have hypertension or high blood pressure. He has diabetes and high cholesterol. And he had his surgery. He has his appendix removed in his youth, and he was taking some medications. He was taking propranolol for his blood pressure. He was taking metformin for his diabetes, and he was taking niacin as well. And probably some of you are familiar with this type of medication. He also told us that his father has some sort of surgery for some sort of thing. So it's interesting to notice that some of us are not open enough to talk to our parents, to our grandparents, and said, did you have any medical problems? What type of medical problems do you have? What type of surgery? Why do they do it? And it's interesting because some people say, they did surgery, I'm not sure. I don't know if it was because of the prostate. I don't know if it was because of the gallbladder. I don't know if it was the colon. So by saying this, I'm reminding you guys, it is very important to know what happened in our ancestors, our parents, our relatives, including parents, children, and siblings. Jojo is married. He has lived with his wife and kids. His wife is a nurse, and she works for Kaiser Permanente. He has 2 kids. One of them is 9 years of age, and his name is Alex, and Megan, who is 12. He's an engineer who works for the BART system. He eats what we call a regular diet, or what he calls a regular diet, and he's stressed out. You know, he lives in the Bay Area. He has to wake up early, traffic. He goes to work, and now he has the financial burden of the high cost of living in Northern California. And in the evenings, he relaxes by smoking. He smokes like half a pack a day. And he also drinks like 2 beers. Essentially, he enjoys his weekends with his family by the pool and friends eating a barbecue. So when we did the physical examination overall, he looks normal. And when we did the laboratory data, we noticed that his laboratory showed that he was slightly anemic. And anemic is usually when the cell count drops a little bit, and we were concerned about that. So now we have 2 things. he was a little bit anemic, and he also passed some blood when he goes to the bathroom. So we decide we're going to take a look, and the only way to really know what's going on in this case scenario is by doing a colonoscopy. Okay? And we're going to talk about colonoscopy in a minute. So hold that thought about Jojo. Okay? So let me go, let's go with the next slide. Sorry. So we have some questions right here that I want to bring. Number one, what is the colon? Where is the colon located? What is the length of the colon? And what is the function of the colon? So to better understand this, anybody have an idea? Let's choose in this side now. What is the colon? Anybody wants to tell me in his own words?
Are you asking
This group, yeah.
colon?
Yes.
I have no idea. I will ask you also.
Okay,
I'm
good. So I'm going
returning
to
it
tell you in a minute. Very good. So now in the right side, where is the colon located? Somebody?
Around the little intestines.
Around the intestines. Okay, and we're going to talk about that in a second. What is the length of the colon? Anybody? How long is the colon? 27 meters. Okay, I'm going to ask, Mr. Romo, please come here. Help me a little bit. My wife is going, Brother Romo. Yes. I'm going to ask my wife to stand by the pole, and Mr. Romo is going to pull the tape measure, and he's going to pull back a little bit. Okay, so 5 feet, not too long. 5 feet, 5 feet, 5 feet. Okay, so for all of them, this is the length of the colon. Isn't it fantastic that God is able to put that much pipe inside of our body? And we're going to talk in more in detail. You can put it down for a second. You're going to help me in a minute. And so we're going to talk basic anatomy, and we're going to talk about what is the gastrointestinal system. So pretty much the gastrointestinal system is all the pipe that goes from the mouth to the anus, okay? So we start with the mouth, and after the mouth, we have what we call the esophagus. So we're going to start, Brother Romo again, to help with my wife. And the esophagus, as you see, you can read it from there, isn't it? Brother Romo, can you come again? So the esophagus is approximately 1 feet and 3 inches. Inches, yes. And so this is part of the anatomy. What happened after the esophagus of the food pipe? Then we have what? The stomach. And hold it. The stomach is 1 feet more, so let's add 1 more feet, okay? So the stomach is once we receive the food and it's passed through the esophagus, then it's when it's grinded and start what we call the digestive process. Then we have what we call the small bowel, which is also called a small intestine, and it's divided in 3 segments. Segment number 1 is the duodenum, segment number 2 is the jejunum, and segment number 3 is the ileum. So let's add we add the stomach already? Yes, the stomach. Okay, so we're going to add the duodenum, which is 1 more foot. 1 foot again. And then in duodenum is when we have some of the absorption, like the iron and other ions and electrolytes. Then after that, we have the jejunum, which is part of the small bowel. It's also called an important organ where we have more absorption, and that one has 8 feet. So we're going to add 8 more feet.
96.
Very good. And then after that, we have the last part of the small bowel, which is called ileum, and that one has 12 feet. Yeah. Round out. So 12 feet would be, give or take, when we add it, how much would that be?
12 feet, that would be 23.
23. And guess what? We still have to add the colon. How much was the colon? 5 feet. So 23 plus 5? Exactly, give or take. That was your question, your answer. Yeah, the whole intestine has 28 feet. Can you imagine the wisdom of God to be able to put 28 feet for us to be able to be nourished, to receive the nutrients, to have the absorption, and again to allow the waste to get out. Thank you very much. We're not going to details. Okay. So one more interesting information about the colon. The colon is a long pipe that the thickness could be from 1 to 2 millimeters when it's distended. It's pretty much like a little paper, that's it. Or when it's contracted, it could be up to 1 centimeter, okay? So most of the gastrointestinal system is pliable. What pliable means, for example, the stomach, that according to how much food do we take, it could distend or it can contract, okay? Excuse me? Expand, correct, thank you. All right, so next thing that we have, we're talking about, we're going to talk a little bit about the anatomy of the intestine. And now the intestine location is, what somebody mentioned right here, is in the lower part of the body. It's called the abdomen. Pretty much, in general, we are divided in two parts, the chest or thorax, and under that there is a big muscle that is called diaphragm, and after that we have what we call everything that continues after the stomach, okay? So now, how is the intestine, which is sort of, a piece of pipe made of tissue, held in place? So there is something that's called the peritoneum. And the peritoneum has two more portions. One is called the omentum, and the other one is called the mesentery. So God is so good that he takes that tissue, which is called peritoneum, and held the intestine in place by putting a membrane that pushes back into the body. And with the mesentery, have two membranes that hold it back. And on top of that, in order to protect it, he made something that's called the omentum, which is a layer of 2 layers of fat. And that fat in between have a lot of vessels and nerves, arteries, veins, in order to give nourishment to the colon, which is or large intestine, and also to protect, okay? The other interesting part is those 2 layers could get big, the fat. So that's why some people are having a big tummy, other ones not so much, okay? All right, so in the portion that we have to your left, we have what we call the ascending colon. And overall, the large intestine is composed of what we call the colon, then the rectum, which is a reservoir, and the anus, okay? What are the different parts of the large intestine? According to what we see, we have the colon can also be divided into parts. The entry point is called the cecum, which is like a 6 inches part of the intestine, and this is where you receive, I'm going to go with this rule for you to show you around. This is where you receive the food coming from the small bowel into this little valve, which is called the ileocecal valve. The interesting thing is once the food that has been digested enters there, that area triggers the movement of the intestine. And this kind of movement is called what? Peristalsis. Peristalsis. Yeah, peristalsis, correct. So what is the function? Okay, so it is divided essentially in an ascending part of the colon, which is from the more left side, the ascending part of the colon. Then once you get up to here, it goes into the more horizontal way. It's called the transverse part of the colon. And then a descending aspect is called the descending colon. This little loop is called the sigmoid, and then that's into the rectum. So right here, also have, in order to give strength to the intestine, there is something called the tinea coli, and these are all the vessels that feed this organ in order to provide 2 things. Enough oxygen supply, and also in exchange where you get the nutrition, okay? And digestion. But most of the digestion occurs in the small bowel. So what is or the small intestine. So what is the function of the intestine? Pretty much, When the large intestine receives the food from the small bowel, as I mentioned earlier, this food has been liquefied by the digesting process, and most of the nutrients have been absorbed already. So the colon job is to dehydrate what is left on the food and also what is from the stool. So in other words is, once you receive the food, it's graded by the stomach. Once it starts passing to the small bowel, all the nutrients start to get into the system, and there is a lot of mucus around, so it's really wet, that part of the food. But when it goes into the intestine, the large intestine or colon start absorbing or suctioning all that fluid and start getting dry little by little. So initially, in the ascending part and transverse colon, this is when all the absorption occurs, and then by the descending part, getting close to the small end, to the small curve that is called sigmoid, pretty much everything comes more solid because all the water has been reabsorbed, and there is a small exchange of electrolytes as well. Okay? So there is very important. Sorry, I'm trying to get my computer to work here. So the other thing that is important to mention is that process of the food passing through that portion of the intestine, it takes a while. It takes at least 24 hours, and also vary depending on what type of food we ingest, okay? So one more thing that is important to say is in that part of the intestine, the absorption or the food that could be digested is fiber, okay? So usually regular food is in the small bowel, but in the colon, usually is fiber. And how is fiber digested? In that area, there is no oxygen, and there is no enzymes or substances that change things. It is digested by the power of all those, they call it microbiota, which is all those microorganisms that cause a chemical process that is called fermentation. And that fermentation allows that fiber to produce something like vitamin B, vitamin K, and still we get some nutrients from that. But the most important thing about this, and I'm sorry we have all these fancy and complicated names, is the formation of something that is called the short-chain fatty acids. We don't have to remember the name, but the most important thing about these short-chain fatty acids is that these substances have the capacity to help the intestine, the cell of the intestines, to be more proactive against what? Against colon cancer. It helps with the fighting diabetes. It helps fighting obesity, and it also helps with your heart health. So those ones help with the cells that belong to the colon. So how do we get those short-chain fatty acids? I'm sorry about these complicated names. There are usually 3 of them. The most important is called butyrate. What happened with this is this type of production comes more common from 3 sources, which are the fiber. And what are those fibers? Fruits, vegetables, and legumes. Okay, fruits, vegetables, and legumes. So anybody could give me an example of legumes? Beans, what else? Peanuts, what else? Which one? Chickpeas, perfect. So pretty much all those beans, lentils, garbanzo, kidney beans, red beans. So fava beans, perfect. Whoever mentioned, thank you very much. So in summary, eating a diet that is rich in fruits, vegetables, and legumes is very healthy for our colon. Why? Because that it prevents, I'm going to repeat that again, it prevents or helping the health of the colon or the cells of the colon, prevent colon cancer, helps with what? Obesity, helps with diabetes control, and helps also with your heart health, okay? So about 95% of the short-chain fatty acids in your body are three. One is butyrate, the other one is propionate and acetate. The important thing is we don't have to remember the names, but know the concept. If I eat a healthy diet, I'm going to have a healthy colon, or my health is going to be better, okay? So I'm going to read right here. It says the short-chain fatty acids may play a key role in the prevention and treatment of certain cancers, mainly colon cancer. And butyrate helps keep colon healthy, prevents the growth of tumor cells, encourages cancer cell destruction in the colon. So let me see what else we have right here. In summary, eating high-fiber food is the best way to increase what? Short-chain fatty acids. And some people advocate for supplements, but the best idea is to try to eat it natural instead of eating supplements. Okay, so next slide. Let me see right here. Sorry, I'm behind with the technology. So as you notice right here, there is, this is an example of what we call the small bowel, okay? And this is an example. This little portion is what we call the intestine. So as you notice, most of the nutrition or digestion of our nutrients are in the small bowel, okay? All right, so let's go with the next one. Okay, cool. So cancer, what is cancer? It's a disease in which cells divide uncontrollably and destroy the body tissue. So the cell is like a little brick that is the smallest unit that can live by itself. The problem is one of those little units start divided in an uncontrollable way. They start causing a tumor, and those tumors progress and cause what we call cancer. As you notice, to your left, you see a normal cell, and to the right, you see the cancerous cell, and the problem is they grow up too fast.
So, doctor, can I ask a question?
Yeah, please.
What causes the irritations of our colon, the lining, that became a cancer?
Okay, there is several factors that may cause that, and we're going to talk about that in a minute. So let me go over the slides. At the end, if I have not answered your question, you can ask me again, okay? But I'll remember, okay? So we're going to talk a little bit about colon cancer statistics, and we're going to talk about incidence and mortality, and the incidence and mortality varies around the world. What is incidence? Incidence is the new cases we're talking about colon cancer, the new cases of colon cancer, especially we're going to talk about United States. In the United States, the lifetime incidence of colorectal cancer in patients is the upper average of 4%. What does it mean? So again, incidence is new cases per year. How many people are here today? Let's see, 34? Who said that number? Okay, anyway, not to worry. So what this means that for every 100 people, 4 of them will develop colon cancer. And that is sort of scary, meaning it is for every 23, 21, 22 male, they may develop 1 cancer, males. For every 25 women, 1 will develop cancer. So this is something to be worried about, and this is what is important to consider our habits. It is more common in males, and it's more common in Afro-Americans than in females. Than white, sorry. So the next thing I wanted to mention about this is data. How many new cases of colorectal cancer occur in the United States? Approximately 153,000. Just to give you an idea, Daly City has like 100 and something population. South San Francisco have like 64,000. So let's say the combined cities of South San Francisco and Daly City, everybody develops cancer. That many occur per year in the United States. The difference, now we are differentiating How many of those colorectal cancers occur in the colon and how much of them occur in the rectum? So just to give you an idea, two-thirds occur in the colon and one-third occur in the rectum. And the difference, what I want to bring this is because the younger population is having more cancer of the rectum or the last part of the intestine, which is worrisome, and we are thinking more that is pretty much related to our diet, okay? Colon cancer is very rare before the age of 40. And the incidence or new cases start more after you pass 40. So I want, anybody younger than 35 want to raise your hand? No one. See, we are in the right group. Excuse me? Over 40, okay. Interesting. Okay. So the mortality is the amount of cases that pass every year, and the mortality for colorectal cancer in the United States is around 50,000 people. So even though we are diagnosed with 150 something, one-third of them die. Why? Because the other ones probably are able to receive treatment. So the good thing is death rates from colorectal cancer have declined progressively since 1980s in the United States, in many Western countries. This improvement of outcome can be attributed, at least in part, to the detection or removal of colon polyps, detection of cancer earlier, and the effective way that we treat. In other words, we have the tools to be checked. As you are aware, in the United States, there is a recommendation that at a certain age, you should go and be checked if you have cancer, colon cancer or not. You could be totally asymptomatic, but if you talk to your doctor, they can do a test for this. The most important thing is this decline has been to the implementation of what we call colorectal cancer screening, okay? One of the most important factors, again, is age. Once you pass age 45, you should be awake and alert. And this rate has significantly increased in the last years between the ages of 40 and 50, and again, we believe in part is for the diet. Let's see. So what are I think we discussed this already. Okay, so what are the risk factors? You asked me what are the causes of cancer. And we have several factors. In general, we divide it in three. We have what we call the multifactorial causes. One of them is genetic influences. And what is that? Usually we have a family history. That's what I earlier encouraged you to ask for your family. Anybody in the family has history of colon cancer? Parents, children, and siblings, especially when we have first-degree relatives. The second thing is when we talk about environmental factors. I'm talking about toxins in the system, nutrition. There are several things that are probably attributed to cancer, but we're not sure 100%, but at least family history, environmental, and the last one is called what we call the lifestyle exposure. And when we talk about lifetime exposure, we're talking about what? Diet, okay? All right, so again, the risk factors associated with colorectal cancer, we have what we call...
Doctor asking about drinking alcohol is one of the factors.
I'm going to talk about that too.
Oh.
So it's very important, and the short answer is yes. Yeah.
Doctor, is it hereditary or acquired? Most likely.
It's very important what you just said. When we talk about hereditary, very little cases are hereditary. As you notice right there, we have less than 5% of the cases are hereditary. There is 3 syndromes that are associated with this. One is called FAP, or familial adenomatous polyps. The second one is called the Lynch syndrome. This is a typical family that develop cancers all over the body. And the third one is called hereditary non-polyposis colorectal cancer. But thank God, this is only less than 5% of the population, okay? The other of the causes, we call it metabolic dysregulation, and this is pretty much affected by our lifestyle. As you notice right there, we have what we call obesity, the metabolic dysfunction, which is people that develop fat in the liver, and again, it's associated with obesity. The sedentary behavior, people that we don't do any physical activity, or we just watch Netflix and don't do much instead of running, doing some walking or doing some type of exercise. The red meat intake. Do you have a question? No. Okay. Red meat intake. Okay. Anybody? What is the red meat? Beef. What else? Beef, pork. Excuse me? Okay. So one more factor, we talk about family history in the colon cancer in first-degree relatives. Other potential risk factors in people that have inflammation of the colon by having certain diseases. One of them is called the inflammatory bowel disease, and that have two groups. One is called ulcerative colitis, and the second one is Crohn's disease. This group may have 5 more chances of developing colon cancer than other ones. People that have been affected by chronic kidney disease may be at high chance, and somehow people in certain socioeconomic status or people that have not availability to be checked by the doctor, okay? All right, so I have a very interesting slide that became very popular in the last few months, and this is about 13, I believe, 13 to 15 cancers that happen or are more common in people that are what? Obese, okay? So we have cancer from the brain, meningioma, cancer of the thyroid, breast cancer, liver cancer, gallbladder cancer, upper stomach cancer, pancreas cancer, colon and rectum cancer, adenocarcinoma of the esophagus, multiple myeloma, kidney cancer, endometrium, and ovary. All of these associated with what? Obesity. Okay, so this came in the news, I think in the last three months. So it's very important. We're talking about again about what? About diet. And as you guys know, Seventh-day Adventists are pioneers and carry the message. The problem is, do we implement that message at home? Or what are we doing about that? Okay, let's go with our next slide. There are 3 ways in which colorectal cancer presents. We have the group that is the asymptomatic person. Just somebody like one of us, they don't feel anything, nothing is going on their body, they just go for a regular checkup. The doctor ordered one test is to check for blood in the stool, they call it FIT test. Or the second thing, they check for colonoscopy, people don't feel anything, and all of a sudden, they find a tumor. That's one presentation. The second presentation is when people have symptoms that are suspicious for, or signs for the disease, okay? And the third one is when it's too late already. People present with abdominal pain, distension, they have an obstruction, they may even have a perforation of the gut, and usually this is too late already, or occasionally they may present with a gastrointestinal bleed. So usually the way this present is like a little growth in the intestine. Initially, it's like a hyperproliferation, which means it's multiplication of the cells, and these cells start to grow slowly. They do not cause symptoms. You don't have pain, you don't have any discomfort, nothing is going on, and eventually they become what we call colon polyps, okay? Later on, they continue growing, and eventually this abnormal cell growth become into cancer, and the problem is when the cancer is spread, and now it's too late, okay? So as you notice, at the beginning it's benign, but later on become malignant. That's why your doctors sometimes tell you, you are at the right age to have a colonoscopy. And again, you don't feel anything, the doctor goes, take a look inside, and they found a little growth, and before that growth become into a malignant tumor, they can go, snip it out, take it out, and the problem at that moment is solved, okay? So now we want to know what happened to our friend Jojo. So Jojo had a colonoscopy, okay? And we want to know what was the result of the colonoscopy. We want to know what is colonoscopy, and we would like to know what tools do they use when they do this procedure. I'm going to kindly request my friend Eric to run another video. This is a short version of what is a colonoscopy. Thank you, Eric.
A colonoscopy is performed with a long tube that has a camera at the end. The tip of the scope can be moved using controls that the doctor holds. This allows the scope to be advanced safely through the colon. The scope is about the width of a finger. The patient is often given some sedation medication for the procedure. The colonoscope is inserted through the anus and advanced all the way to the beginning of the colon, where the small bowel ends and the colon starts. The scope is then slowly removed and the colon inspected. The doctor is looking for growths or other abnormalities. Growths in the lumen of the colon are called polyps. If a polyp is seen, it is biopsied, which means it is removed to be tested. If a mass is large, like a cancer, only small portions of it might be biopsied. The biopsy tissue is sent to a doctor called a pathologist. The pathology doctor will examine the tissue under a microscope to decide if the polyp is dangerous. The pathology report can take several days and is not instantaneous. If the biopsy shows a polyp that is high risk for developing into cancer or is already cancerous, more procedures might be needed.
Okay, any questions about a colonoscopy? Okay, that's a very important question. Usually, colonoscopy is indicated, give or take, around age 45 nowadays with the current incidence of colorectal cancer. And if your colon is normal, usually they recommend or advise to do it every 10 years. Why they have chosen that amount of time? Because usually in that period of time, you are able to catch up if there is new growths. On the other hand, if your doctor tells you, I found some polyps or some growths, I want to come sooner. And that depends what the findings are, meaning the more polyps they find or the larger they are or the method of removal, that put you at higher risk to developing, again, more polyps or more growth, and as such, more cancer. So in some people, there are significant factors that increase the risk of polyp formation. What is those? Number one, age, and the age you cannot change. Once you pass 45, you are at risk. Number two, depending on what you eat. People that consume red meat, people that smoke, people that drink alcohol, they have a higher risk. So those people are more prone to develop colorectal cancer, which is fantastic for us because as Seventh-day Adventists, we have the message. By definition, we don't do most things, and a lot of other people have taken the message to their heart, and they try to consume very little amount of red meat and increase more fruits, vegetables, and legumes or grains, which is great. So your question was, can I do something else? I'm not asking you in public, but if by any chance there was an indication to you have more colonoscopies based on the fact that you have more polyps, there is a chance that you will have polyps again, and okay, so the best bet is there is nothing else at this point that just accepting the fact that you may need another colonoscopy and have those polyps removed. Trying to ignore that is not a good idea. Okay? Any more questions? Yeah.
Because every year My question is, does colon kit that the Kaiser or any hospital send it to us, it is accurate?
It is a very good tool. They're called fit tests. In fact, there's studies that they have been able to decrease the incidence, and again, incidence is new cases, of colorectal cancer by more than 50%. How accurate are those? Usually we use the word sensitivity, which means how good they are in detecting blood, number one, is around 95%. So that test is very good. It's very good. It's not perfect, but it's very good. The same as the colonoscopy.
That's 90%, that is really good.
It's very good. See? So by having that, and if it shows that it's blood, I think the next step is going to be a colonoscopy. Okay, so yeah, it's a good thing. On the other hand, if you feel that you have risk factors or you push a little bit, you can have a colonoscopy anyway. Yeah.
Because, in my family, both side, my dad died cancer, my mom died cancer, but it's not a colon cancer. So it is possible also rest to the family history, both side that has a cancer, but it's not a colon cancer that, the family can get a different cancer like colon.
This is an important question, and the answer is, as I mentioned earlier, there are certain syndromes that could increase the chances of cancer in families. Like, for example, the Lynch syndrome, which may present in people that one have breast cancer, they have gallbladder cancer, the other one has colon cancer. So if you have in your history and data, you should bring that to your doctor.
All of them died like lungs, lipoma, and then bone cancer. But I never heard like a colon cancer.
Regardless, as I mentioned, the Lynch syndrome it could be any cancer. So by saying that, it's important that you bring that to your doctor and say, I'm concerned, I would prefer, and I'm asking you to do colonoscopy instead of the stool test. And it's acceptable. No, the stool test is one thing, and the other thing is colonoscopy.
Yeah, because these told me that you're not in 50, so they started doing colonoscopy when you reach 50. That's the doctor told me.
Now the age went down to 45. That happened the last 2 years.
Oh, okay.
So
but I just received only the colon kit.
Okay.
But thanks God,
Yeah, everything has been
it's
okay.
a good result.
Thank you. Go ahead. Yes. Some cancers are more aggressive than the other ones. So usually, that's a very important question. The layers of the colon usually are like 4 of them in basics. We call them mucosa, submucosa, muscularis mucosa, and serosa. So it depends on what is the extent, how deep into the colon it has invaded. The second thing is, it's not just to have it, it's to remove it or get rid of it. Sometimes if you have the blessing to have the insurance and go with the doctor and they take it out, sometimes you are cured because it's just superficial. If it's a little bit, more invading, we have other techniques like radiotherapy or chemotherapy, and based on how much is spread, the data changes. But the more invasive it is, or the more spread it is, the lower the chances.
What does colorectal cancer start?
What was the question again?
Yes. How does colorectal cancer start?
Okay, usually, as I mentioned earlier, it's like a little, let me go back in my slides. Sorry. Okay, just like that. As you notice, there is an overgrowth of tissue, or we call it hyperproliferation. That little lump is the one that is detected when people have a colonoscopy and is removed on time. But we don't do anything about it. We ignore it, and we don't do the right test. It starts growing and growing to the point that it invades, and that's how it happened.
The reason I'm asking, Doc, is because we are prone to cancer. My family My dad died of lung cancer, and then I had an uncle who died of colon cancer. And then I had the cancer of the breast, and then my daughter is starting to have a cancer of the breast too. So we are prone to cancer. That's why I am very much eager about learning about more cancer.
Thank you. So yeah, it is important to note that the risk of colorectal cancer goes when your relatives, I'm talking about first degree relatives, including parents, children, and siblings, develop cancer when they are 60 years of age or younger. So let's say my grandma have colorectal cancer at 80, that does not increase my risk. Increase my risk only when my first degree relatives are 60 years of age or younger. I'm just talking about colorectal cancer. Go ahead. I couldn't hear it. It could be, as I mentioned, there is some groups of people that may develop cancer because genes.
Doc, before you proceed, is there any like an option for a person who has some symptoms? Because we know that this is the second highest rate for death,
Yeah.
combining men and women. But is there any like option for a person who has already that risk to skip the colonoscopy? Is it too late for a person who has that already symptoms to undergo colonoscopy, or is it still applicable for that?
Okay. Let me see if I understand the question. Is there anything else than colonoscopy for me when I have symptoms?
Yes.
Okay. I tell my patients, when I'm in my desk and the patient asks me, is there anything that I can do? I just tell them this. Do you know what is inside of my drawer? I have 3 drawers in my desk. Do you know what is in this drawer? And they said, no. I say, I just come here once a week. Neither do I. What is the only way for us to find out what is inside of that drawer? And they tell me, look inside. So we opened the drawer and we found, there is a stapler, there's something. So we want to find out what is inside the colon when you have symptoms. The best way to do is to look. And thanks God, because some people say, no, I leave it in God's hands. No, God already gave you the tools by having doctors, by having insurance, by having tools like a colonoscopy to be able to do it. And I think that's the best way that I explain. Go ahead.
I'm sorry, this is not a question to you. It's just a comment. Cancer has many, many factors. And sister, it can be genetic. Even if we have these genetic markers and everything in our family, they're usually dormant. Dormant means they're just sleeping. Now, if we trigger them, and one of the triggers, for example, is diet, if you have predilection for cancer, especially colon, and you keep on eating the things that are not good for us, then you're higher risk of developing cancer. And some people actually proactively trying to get that test. Those are expensive genetic tests. For example, Angelina Jolie, right? She was diagnosed that, okay, you have these genes, you're going to develop cancer in such future. What did she do? She take them out and change it so that
When
the
you say
risk
take
will
them
be
out,
lower.
she removed her breast.
Exactly. Remove the breasts, both breasts.
That's very aggressive, but she said,
Very
I don't want to have it.
aggressive. You don't know when you're going to have it, right? But some genes, for example, can predict you might have breast cancer with this gene in 2 years. Probably that's what she has. So that's why do I want to have breast cancer in 2 years? Just take it out or take a preventive medication, which already anti-cancer. But these are only different types of cancer. So not all of the cancers like that. But it's true, if you have family history of cancer, there must be is called pre-oncogene, means a gene that can develop whatever cancer it is. So, but nobody does that unless really you have high cancer in the family. But then there are some genetic counselors. Kaiser, for example, me, okay, my mother developed cancer at 92. Do I have high risk of developing cancer? No. Because as we age, our cells deteriorate. It's not normal anymore. So anything can happen to our body. But if it's a young person, like with normal 40 years old, 30 years old, and there's some deteriorated or metaplasia or dysplasia, meaning altered normal layer, there is a sign there that it could develop into something. That's why we need those preventive procedures. Those are recommended by all the doctors, for example, gastroenterology organization, because it's been studied for many years. If you have cancer, colon cancer at 45, or your dad died at 50 for colon cancer, the daughter, the son, must have a colonoscopy every year, doctor?
10 years earlier than, 100% high risk. But you have to be specific about what type of cancer.
Oh, my mom.
Not with me, but in general,
No, it's
to
not
your doctor. Yeah.
That's why my question earlier, you know,
Yeah.
it's possible to the children to get a colon cancer if your parents died both cancer, but it's a
Yes.
different cancer.
Yes.
Definitely, right?
Well, unless it's what we call certain specific syndromes, which those syndromes occur in less than 5% of people with colorectal cancer, then it's increased. But if there is a family history with many cancers in relatively young population, I would highly recommend colonoscopy. By the way, having a colonoscopy is also being responsible. Do you want to leave a burden to your kids? Only because we want to be stubborn? No, that's not for me. Nobody wants me to look in that area. So that's what I said, it's a scientific part. Do I want to give that burden to the family? When God has provided science, doctors, and tools to be able to do what we have. Somebody has a question? Go ahead.
If you are in a family with different sort of cancer, say like my father died for a lung cancer, I have an uncle, first degree cousin of my father which died in colon cancer, and there's that cousins that died in breast cancer. So my concern is, if you're at age like mine, 50-something, secret ang kida. So if you are at age and you are seeing that you have relatives around died for cancer, several kinds, so would CA125 blood test help in determining cancer in your system?
Again, there is very clear data about recommendations in screening. Screening is, let's take a look. A blood test may give you some information, but it's not the same as a colonoscopy. Colonoscopy, you're looking, you're opening the drawer, you're looking what is inside, okay? So I know some people are very reluctant, and you have the right to do that. But if I had insurance and we were so blessed, like we're in America, that you can have a colonoscopy, I would go for it.
Those markers are not really very specific for certain cancers. So blood test is just, how do you call it, suggestive, but it's really not going to tell you that you're going to have or you
Not
have
at
the
this
cancer.
point yet. There may be some new tests coming in the future, but as Dr. Mercado, my wife, said, yeah, at this point, I will go for what is the recommendation. The same thing for breast cancer. Go for your mammogram. Go for your check. The same for cervical cancer. Have your pap. Those are again, some people say, I will leave it up to God. No, God already is providing. Most of us right here, we have insurance, and there are some clinics that let you do it too. So I encourage you to really take responsibility in your health.
Can I
Yes, Pastor?
echo that? 125 is not only for one type of cancer. So it's so many cancers, it will not point to you where to go. So, no, it's not the way medicine is. Medicine, if they do
If-
that, they were suspecting already, then you have to have a actual workup for it.
So-
It's not just a blood test, yeah.
Even doctors, we are advised and recommend do not do those blood tests unless you already have something. Example, for colorectal cancer, we have one that is called the CEA, which is carcinoembryogenic antigen, and the CA 125, but it could be in other cancers. The problem is once you have it high and then you don't find anything else, what are you going to do with that? The person is going to be all stressed out. Then you have to do what we call $1 million workup, and then you don't find anything. So at this point, it's not recommended to do
Yeah, they
those
do
tests.
that when suspect direct something cancer, say ovarian cancer or something like that. Exactly, but going from the blood test towards finding a cancer is not the way to go. It's the other way around. If you have a suspicion, then they do the blood test and they do the actual procedure. Because the procedure, the biopsy is a final decision whether you have cancer or not. It could go, I get nervous, 125, do I have ovarian cancer? Do I have uterine cancer? You have colon cancer? Do you have all kinds of cancer is increased with 125. So that's not the way to do that. It's the other way around. If I'm a doctor, I'm highly suspicious of certain, okay, you have a pap smear, just an example, or uterine cancer, or even a ultrasound that has huge ovary. Okay, let's do this test first, and then go to other workup. It's not, I like 125, I want to see what cancers I have. No, that's not the way to go.
Thank you.
To disclose to the doctor your history,
100%.
what your lifestyle is,
He will know by looking at you.
because some patients doesn't disclose. They don't doesn't wants to hide something.
That's cultural, and especially some parents never tell the children, hey, I have prostate cancer. That's another one. But the important thing is, yes, you should tell, and in America it's not uncommon to say, anybody in your family have colon or rectal cancer.
Sorry, I keep on interrupting. We the Filipinos, we don't like anybody find out something what we have. One. Number
Latinos too.
Number two, in the Philippines, nobody goes to the doctor unless they're dying or emergency room or something. So in America, we are blessed that there are preventive medicine. That's why, for example, Kaiser, you are due for pap smear, you are due for fit test to see if it's positive, you go colonoscopy, you are due for this and that. So that's the most important. But before going to that and being detected of something, let's eat healthy the way that we are taught. I'm not 100% following, but
At least try.
But we try.
Okay. If you allow me, we would like to know now what happened to Jojo. Remember Jojo at the beginning of the talk? So Jojo had a colonoscopy, and Jojo was found with a tumor close to the rectum. Okay. Initially, there were some polyps. This is real life how they look. A polyp is a growth. It could be flat, or it could be like a little, like a fungus, like a mushroom. Okay. But in the lower right corner, you see what is a cancer, and probably that is already invasive, which means if he has not done this, probably he would have died from this complication. I want to take a little few minutes, and I want to have 2, 3, or 5 hands of who wants to play doctor today. Okay, there is one. Who else? Okay. So who else? Anybody else? It's very simple. So we're going to fake like there is some polyps right here in the table, And this, I want just to show you some of the tools that we use during colonoscopy. By the way, while we prepare this, it's very simple, that's enough, I think. So by the way, while we do this, what we're going to do, we're going to open some of the gadgets that we use during the colonoscopy, and we're going to play that this little rule with the lumen inside is a colonoscope, and we're going to try to grasp those little polyps. We're calling polyps, those beans, okay? Colorectal cancer. Yeah.
So my question is, what is the overall survival rate of that person?
Very important question. The answer, I don't have it yet until we do something else. With this, during the colonoscopy, I am able only to look inside the pipe. Now that this is spread, we want to look outside. And how we look outside? We do what we call imaging study. We do a CT scan, we do an MRI. Sometimes we may need to do something that's called endoscopic ultrasound in order to look for the organs to see if there is an invasion. If it is really invaded, depending on how far it is, probably the survival may be good or may be bad. So at this point, thanks God, he was able to get the tumor resected. He received some chemotherapy and radiation, and we hope that the survival rate in his case is around 70% at 5 years, okay, which is acceptable. The problem is when we are in denial and we don't do much. Go ahead.
So depending on the stage of the cancer.
Yeah, that's called staging, yeah.
So this.
I questioned that to the doctor, when my husband is already diagnosed with rectal cancer. He told us that his life is only 3 months to 6 months. But we asked God to give him 2 years more to spend his life with us. My question to him is, he's an old doctor in ER and Seton. Why you know the life of a person, that he is dying? Why you know I told him, you're not God. Why you know his life expectancy?
You're totally right about that. Pretty much the information.
Why can you tell us, doctors, why you know the life of a person who is like that kind of disease?
Yeah. I'm trying to answer, and you're correct about your concern. Pretty much we provide information based on data. So data say we do a staging. A staging means at what stage of the disease the person has. Is this localized? Is this has metastasis? Metastasis is when it's spread. For example, in colon cancer, there is common areas of spread. One is liver, the other one is lung. But sometimes the problem with the rectum, and hopefully, let me see if I'm going to I can show you in a slide in a second, the distribution of the vessels may allow sometimes the spread to go to the brain. For example, rectum, sometimes it's easier to go to the brain than if you have it, let's say, in the cecum. Why? Because some areas of the cecum, the vessels are closer to the lungs or to the liver. But somehow the distribution may allow the metastasis to be worse. So for example, once you metastasize to the brain, is not good news. I don't know the details about your situation, but it pretty much depending on the stages. So once they look at the person and say, you have it spread here, here, and there, and the chances for you to be alive if you receive treatment may be this. At 5 years, your survival rate may be 90, 60, 50% or less. So you're totally right. We are not God. But it's just a guide. It's just guidelines, the chance, because people want to know, do I have chance? Can I go and visit my grandchildren? Should I visit them before I receive chemotherapy? Should I, my daughter is getting married in 3 months. Can I wait surgery for 3 months? If you wait surgery, the chances are they're going to progress. If you have surgery right now, maybe your daughter can yeah? So, yeah, we're not God, but we have just guidelines, okay? Go ahead.
So basically, the doctors are telling you estimates. Estimates of, say, because it's years and years and years of experience, the doctors, for example, gastroenterologists or kidney doctors, have guidelines, for example, what stage is this, stage 4, so these are the possible treatments. If you go through all the treatments, the possibility of living in 3 years is 20%, just an example. So these are the data we are following. It's not because I'm the doctor, it's my decision to say that. It's a decision of many, many millions of doctors in the world that decide this. For example, also the good thing is chemotherapy is so advanced now. So sometimes, I hope I don't hit anybody. So sometimes, for example, somebody has a pancreatic cancer, a pancreas. In general, you're the specialist on that. Even though I'm not a doctor, I'm not his specialty. I will say at best 3 months, okay, at best. But depending on the stage, people can even live on 1 year, because I see it, 2 years, because of the most recent chemotherapy that they are giving. So even if I say, oh, kidney failure transplant, I give you 5 years. I have patients for 27 years, still alive. You know, so those are just guidelines, but there's some things that really can be extended with the help of God, of course. Yeah.
Even when people develop metastasis, or meaning extending of the colon tumors to the liver, we have new data proof that taking the lesions that have spread out may prolong the patient's life. So what we're saying today, maybe in the future years, is going to be different because the technology is improving. So anyway, who was going to play doctor? You? Okay, so we're going to go ahead. Huh? Lucille, can you open? So reaction, possibility of bleeding, possibility of infection, tear, and even death. But the risk of having the procedure versus the benefit outweigh the risk, okay? So this is an example. So right here, I'm going to give him what we call a biopsy forceps, and yes. Sorry.
Doctor, conductor.
So basically, once we have the device and the doctor goes and see a little polyp inside the intestine, usually these pictures are really enhanced. To give you an idea, the lesion that is on top of the cancer is probably 4 millimeters, okay? Polyps that are less than 1 centimeter usually have lower risk of colorectal cancer. Polyps that are more than 1 centimeter, we call them advanced lesions and are higher for development of colorectal cancer. So I'm going to ask you to hold this. Give me a second. So this is what we call a biopsy forceps. All right. So in real life, I have a technician. So let me explain about the colonoscopy a little bit more. The colonoscopy is done in a very private setting. Our teams are really usually prepared to deal with privacy, and we understand, the fear of the patient. The patient is given a medication through the IV that provides two things. Number one is give you some sedation or relaxant or calming medication. The second one is going to provide you some medication for pain. Once you receive those two medications, the patient, usually our room, have the lights off. We put some lubricant in the area, and we pass the camera in the anus and rectum, and we drive the camera by moving the tip and going around the intestine. Yeah. Okay. So I'm going to be the colonoscopy, and you're going to be the nurse. So you're going to give me this, and right here, if somebody wants to get closer.
No, nurse na lang.
The same. Okay. So open, and close. So if anybody wants to come close, you can see it.
That's the one that can pull the polyps?
Exactly. This is called biopsy forceps. Come close, so you can see better. Look at this. Okay, yes. Open, close. Open, close.
That's $30.
Open, close. See? Yes. Exactly. Okay? All right. So in this case, I'm going to, let's say this is the colonoscope. We're going to feed it, and this is pass. Once it's advanced through the colon, then we're inside the intestine, and we're going to try to find a polyp right here. And here I have my nurse. So once I see my nurse, I'm going to ask my nurse to please open. And then we're close. Close, please. Okay. One more time. Okay. Somehow, this one has a needle in the middle, and it's slippery, so I cannot catch it. But in real life, if you go with a polyp, close. Yeah. Look at this. Hold it. See? I get the little sample. I cut it out. Yeah. So that's one example. Anybody want to test it here?
Come on, it's free.
Yeah. Thank you. So, yeah. So, like this, open, and close. Open again. Once it's open, if you notice, there is a little needle in the middle. So with that, you anchor the lesion, and you close it. Okay? Anybody else want to try?
Doctor, for a day.
Go ahead. See? Right there. And let's go ahead and get a little piece of a lesion right here. Open, please. Okay, you have it there. We go to the corner right there. And close. Close. Tight. Okay, now we're going to pull out. And now we have a little bit sample. See, you open right here. See? Open. The open is away. Yeah, it's open. Now we have the sample right there. So this is what is submitted to the pathologist. The pathologist look at that in the microscope, and we take it out. Okay? So this is one device. Okay? Close it, please. Close it. Okay. So we have another device. Be careful. This one have a needle. So this is brand new, so it's okay. And as you said, costs $30 to $40, something like that. Okay. The cameras that we use are very expensive. They cost between $30,000 to $60,000. The camera only. The whole equipment costs like $180,000. So it's very. So I'm going to open another device right here. Brother is going to help me, and this is called an snare. Okay. Another different tool. So if anybody wants to get closer. Okay, this is called an snare, and this device is a metal that goes into this sheath. Once you open it, it opens like a little circle. Go ahead and open it. Okay, all the way, more. See, so once we have the polyp, Probably you see that in the video. I'm going to give you an example. Close it again. Close, okay. We're going to pass it through the scope, through our formal scope. And now we are inside the colon, maybe in the sigmoid area, and then I'm going to ask you, please open the snare. Open, and then I go on top of the lesion, and then I say, close the snare, close. And now the area has a current. So this has an area that you connect with electricity, and that burns the area or the base of the polyp, and the polyp is removed. I have suction right here. I apply my suction. The polyp comes through the channel. We collect in a little bottle, and we submit it to the pathologist.
Explode, that polyp is not gonna burst out. Just, yeah, burn, and then it's, oh, so it's not gonna.
Biopsy was this is the one that had biopsy. Yeah, this was anybody else?
And this one is
This one is for,
This is called a snare.
snare.
Open all the way.
parang
Open, see?
Yeah, no? Oh.
Actually, I got in 3 years, I already got colonoscopy. They found two, so they take it out. It's not cancerous, but they just take it out. So that's
Good decision.
5 years again.
Ayan, ikakat.
Anybody else want to see or try?
parang yun pala yung
Try. David.
David. Oo, yun nasa loob.
Go ahead. Open, please. Open. Keep going. More hard. No. More open. Like this.
More open?
All the way. Open.
way?
Yeah. Keep going. More. Keep going. More.
Which way?
The way that you're doing. Yes. Keep going. Yeah. Open. Okay. More. Okay. So now you go under the polyp, and now you close it slowly. You close. Very good. Exactly like that. Okay. So if you guys want to have an idea of how the gastrointestinal system is, we have an example of the stomach, the colon, and as we mentioned earlier, the colon frames the small bowel. You learned that? Very good.
As a peptic ulcer,
Yeah.
and they found a small hole in a small intestine inside.
Wow.
And they put in hospice, they can't do any surgery because he's turning 85 years old, and his liver is bad. They cannot able to. Yeah, so, and there's blood in his stool right now. So what he can do is just
Pretty much, at certain point, when the person is at certain age, doing any procedure could be a risk, and at this point, probably it's giving comfort care.
he got there's cirrhosis also. They just had the same this July, end of July.
Is she here on the Philippines?
It's there.
Yes. I'm sorry.
And there's every time he got boobs, he got blood. So I'm just asking if the activated charcoal can be able to clean the toxin. Please, no.
Probably if she already has cirrhosis. We can talk more after I finish here. We talk more, okay? Open this. Open it. Like this. Put your finger like this. With this. Okay. Pull it out. Like this way. Okay. So we open. Okay. Now close. See? That's how it works. Okay. All right. So I will try to summarize. I thought I was going to talk like for 5 minutes, but it seems like it's I didn't mean for you guys to get so tired. Let's close this, and so overall, let's go briefly about what are the symptoms of colorectal cancer, and let's go. The typical signs and symptoms include common things: change in bowel movement habits. Hey, you are a person that usually go to the bathroom in a regular basis, once a day, once every other day, and you have no problems, and all of a sudden you start with having loose bowel movements, or you have constipation. Constipation is, by definition, is when you move your bowels every 3 days. This is one of the most common symptoms. The second thing associated with colorectal cancer is having change in bowel movements habits and also having blood in the stool. Okay, so that's another very common symptom. The third thing is having a mass in the rectum. So when you have something, some fullness or something not normal right there, this is the time to be checked. And this is not a way to avoid colonoscopy. You want to be checked. Another thing is having an abdominal mass. Usually when that happens, it's too late. And this is last on the list. Other ones, when they found you with anemia, which means low cell count. Why? Because sometimes you don't see the loss of blood, but the people are having loss of blood. So you have to be sure you are not having blood in the urine, or probably when you go to have a bowel movement. And the last one probably is also abdominal pain. So let me go forward right here. So these are some of the symptoms. And moving forward, other common symptoms that are not as common is abdominal distension. And the last one, when you come to the hospital already with nausea, horrible abdominal pain, these ones may be an indication of obstruction, meaning that the mass has grown so much that now you are obstructed, and that's not a good sign. Okay, some people have some unusual presentation, which is called a fistula. That means that the intestine have a hole and the hole has gone somewhere else, like let's say the bladder, or also when they start having fevers that they don't know from where. This is another atypical presentation, or when they found already a spread to other organs, such as in the liver. As you remember, we say common presentation is when they have, common presentation or common metastasis, or where the cancer goes somewhere else, is liver and lung. Okay. Let me move my slides right here, sorry. When the patient has symptoms, probably it's too late and maybe advanced disease. By saying this, I again encourage you to follow the guidelines of the doctors and be screened or have the test while you are healthy. Don't wait until it's too late and you already are sick. Okay, let me see what else we have right here. As we said, the diagnosis is made when we take the sample and give it to the pathologist. He looks under the microscope, and now we prove that people have cancer. We talk about the colonoscopy, which is the most accurate and versatile diagnostic test for colorectal cancer, since it can localize and diagnose for the tissue. Okay, and how is it treated? There are 3 types of treatment. We talk about those early. Number 1 is surgery. Number 2 is thinking about chemotherapy. And number 3 is radiation. So this is probably the home take message. How do we reduce the chance to develop colorectal cancer? Number 1 is maintain a healthy weight. As you hear early, being obese increases the risk for many cancers. Number 2 is limit alcohol intakes. You asked me about that? Yes. And in our case, I wouldn't say limit. You know, the best principle is no alcohol at all. Number 3 is smoking, and smoking is proven to increase the development of colon polyps. 4, very important, know your family history. Get a screen at age what? How many? No, I'm not going to ask that. Okay, and the last one is eat a balanced diet. When we talk about eating about balanced diet, I will go over some details in the minute. There's also, be sure that you are active in your physical activity, your diet, your fiber, whole grains. We talk about that already because that stimulates the short-chain fatty acids and vitamin D. And I'm going to finish with this one, which is again about the diet, okay? Rich, non-starchy vegetables, fruits, whole grains, dairy, fish, because they stimulate omega-3 and fatty acid, limit the red meat, meaning beef, pork, and lamb, and avoid processed meats, those ones that are cured, salted, or smoked meats, okay? With this, I conclude our topic. Thank you very much for your participation. Go ahead.
Yeah, normally, patient, person have a bowel movement every day. But in case that the patient don't have a bowel movement for 5 days, is that normal? Is because, sometimes doctor recommends some laxative. In spite of laxative, still you don't have one. So is that still normal?
No, it's not. That was a very important question. By definition, constipation is when you do not have a bowel movement in 3 days. Obviously, this is affected by different factors, especially diet. People that use or eat fruits and vegetables, vegetarians, they may have several bowel movements a day. And people that eat meats, usually they are more prone to have constipation. In the other hand, it's good to be checked. Sometimes something like thyroid dysfunction. When your thyroid is not working well, you may end up with constipation. People that are bedridden, they're very common to have problem with bowel movements, especially people that have malignancies where the calcium goes up, so the bowel movement is also decreased. Yes, so once you don't have bowel movements at least every third day, definitely that should be investigated. Okay, my wife reminded me also that people that take narcotics, and narcotics like hydrocodone, oxycodone, all these type of pain medications decrease the motility of the bowel, meaning they don't have regular bowel movements. Another common problem is people that have diabetes when they are poorly controlled, meaning the sugar levels is sky high. With those ones that are familiar with a test that is called hemoglobin A1C, when that one is very high, you have very high chance to develop either constipation or diabetes. So definitely not having regular bowel movements should be investigated.
Yeah, I have a question. I find colonoscopies too invasive. So aside from the stool test, is there any alternate test for colon problems, like a 3D and something like that?
Okay,
that utilizes 3D.
Yeah, there is something that's called CT colonography, which pretty much is a imaging or a computerized tomography of the body. The problem with that one is, number one, it's very expensive. Number two, it can open a big can of worms, meaning you are looking for masses or screen for colon cancer, and you may find a lot of things around that may end up in a very expensive workup, and sometimes it's not worth it, the test. So for example, there was one of the doctors had that, and they found like a little lesion in the spleen. They did several studies, including surgery, and it happened that the guy in his youth had tuberculosis, and this was like just a fibroma, like a scar tissue. So at this moment, it is an alternative, but most of the insurances do not pay for that. Some insurances do, most don't. In certain patients that, for example, have contraindication to do a colonoscopy or definitely don't want it and we're really concerned, we can ask for that test. But in general, it's not like the first in the line. The gold standard so far is colonoscopy, and then if you fit test is another alternative, okay?
Doctor what is the very ordinary chief complaint of colorectal? Please.
We just mentioned those. The number one is changing bowel movement habits, and the other second one associated with that is blood in the stool.
No, I mean bloody stool.
Yeah.
No pain.
Well, that one too, but you asked me for the most common ones. So I have a list of them.
What about the one that it looks like that you are sick, but you don't have pain? Sometimes there are some patient who goes to with complaints but no pain. What is that colorectal chief complaints
Okay,
of the patient?
this slide again remind us the most common one is probably changing bowel movement habits, and the second one is that one associated with blood in the stool, and then we have other ones like abdominal pain, we have rectal mass, we have fever of unknown origin. So I think whenever you find something that is not normal, it's okay to be checked. So we can make a educated decision about what test should we do. Okay?
What is the normal BM? A day, one, day two,
Okay.
day three.
Usually anything between several a day to up to no more than 3 days, and also based on our diet. As you are aware, people that eat fruits in countries in Africa, they may go 10 times a day, and that's normal because that's what they eat. In our American diet, if it includes meat, some people have time going every 2 or every 3 days. So it varies.
So I think that's abnormal for 10 times because that is LBM now. I was talking about the regular BM. Is it every day you should have one? Can you please bigay mo na sa kanya.
No, it depends on what you eat. Some people that eat a really high,
No, for the normal, you have to have one once a day. That's for you supposed to be normal. But if you eat a lot of fiber every day, so you have like twice or thrice a day.
it's also normal.
Yeah, for me it's normal, twice a day,
Yeah.
because when you just exercise and eat vegetables a day.
Exactly.
So that's normal. So if you does that every day in your life, since when you are a child, that's normal. But suddenly it does change, like, oh, it's already 3 days. I never went to the bathroom. So that's not really normal, right?
Yes. Okay. Thank you very much again.
Question,
Yeah, go ahead.
Okay. Because I was concerned about like anemia. If you are low blood pressure, you consider as an anemia?
No, not necessarily.
Does not?
No. Low blood pressure could be associated with several factors and not exactly related with anemia.
So it's not considered as an anemia.
No, blood pressure is one thing. Anemia is low cell count. Usually we have 3 types of cells. In summary, one is the one that carries the oxygen, hemoglobin. The other one is the 5 which is the white blood cells. And the third one is the ones that clump to when you have an accident or like a cut, and those are called platelets. Of course, there is more subdivision and everything, but we're talking in general about hemoglobin. When the hemoglobin goes down, usually we call it anemia.
Okay.
And that could happen for different factors that we can discuss in another conference. Yeah. Okay, thank you very much.
Thank you, thank you. Are you blessed? So we're very blessed. We have not just doctor, but specialists in our church. So we should be grateful to the Lord. And Dr. Joel, you see, you just have a topic of colorectal. There's more to come. What is your next topic that you want so that we can tell it to doctor about the GI? That's a lot. We only discuss one. From mouth to the rectum, it's all GI. So, Doc, when are you again available to? I asked Dr. Lucille, and she said November she will discuss on the kidney. But on October, we have cooking class coming. Brother Josh will teach us about vegetarian food. If you see the the tracts or the paper that Dr. Joel gave. It's about healthy diet. And we will be learning cooking class, healthy vegan food. Brother Josh, I think, will lead us on the second Sabbath, because the second Sabbath of October is youth program, and he invited a speaker to give us a message, and then on the afternoon, instead of the third Sabbath, it's a second Sabbath, he will teach us to have a cooking class. So we'll be busy, and then on November, December. Doc said you will be giving us a lecture on December.
Next to that, I'm going to recommend you're going to have a dermatologist to have gestures for a beauty skin.
Okay. So that's so remember, Derma, she will invite, do you know Dr. Bello? they don't know Dr. Bello. So thank you, Dr. Joel, and
Demonstrate our product and to make you beautiful without any surgery.
okay. So thank you very much. Hopefully you are blessed, and you will invite more friends, not only us, but some friends that you have, so that we can also teach them about healthy lifestyle.
470. 470.